people were there.
That
That means
Rachid
around totally around 13, 14 people have not got the visa at all to come. This thing, permission to come.
Okay. Yeah.
Where,
So,
sir?
13
I
version
missed
6.
because I was on a phone.
Sir, Dr. Manira has to be, sir, co-host banana hai, sir. She is, otherwise she cannot share the slides. You are the host.
I'm the host, okay.
Yeah, you are the host.
Hi, Dr. Rachid. Welcome.
मैं co-host. Manira is
आप
co-host.
म्यूट पे हो डॉक्टर रचित. डॉक्टर रचित भी है ना co-host.
Sir, good evening, sir.
Hello.
Vishal sir, good evening.
Hello, good
Rachid
evening.
Sharma Saab, good evening.
I
Sir,
think
good evening, sir.
Vishal, how are you?
Recording started. Yeah, is the slide share coming on?
Yeah.
Yes, thank you so much. Welcome everyone to this 240th edition of Thursday Musings. So today we have a non-psychiatrist speaker who will teach us about hypertension, what a psychiatrist should know. So the meeting is being recorded. This will be put on the YouTube platform. Everyone is to be on the mute mode. Questions will be invited in the chat box. So you put your question in the chat box. The moderators will take it up to the presenter. Yes, and my pleasure in handing over the session to the chairman of this program, Professor Dr. Tufan Pati, sir. Over to you, sir.
Thank you, Dr. Elaine. So we are in the 240th episode of Thursday Musings. And we have with us Dr. Amit Patadasi as moderator. Maybe he will join from a distance in between. Dr. Alim Siddiqui, Dr. Vishal Chabra, and Dr. Shobit Garg. And I have the pleasure to introduce our chairpersons, dear Dr. Pavan Kumar. He is Professor and HOD Psychiatry of KIMS Karim Nagar, Consultant Psychiatrist Sirama Hospital Karim Nagar, Managing Director Sinaf Child Development Center Karim Nagar. He had been the Honorary Secretary of IPS TSB 2021 to 23 and editor IAPP Telangana State Branch 2018 to 20, Assistant General Honorary Treasurer of Indian Psychiatric Society, recognized UG and PG teacher from Kaloji Narayan University of Health Sciences, Telangana. Have published articles in index journals, authored a chapter in IPS Southern Publication, Indian Psychiatric Update, Psychiatry and Medical Education. And his areas of interest, key focus areas in psychiatry, consultant liaison psychiatry, ECT and child psychiatry. Specific research or clinical interest lies in psychiatry. Other areas of interest, digital diagnostics and psychiatry. Welcome, Dr. Pavan Kumar. Next slide, please. Dr. Rachid Sharma, Associate Professor and Head of Department of Psychiatry, Military Hospital, Meerut. He is MBBS from LLRM Hospital, Meerut, and MD from AFMC, Pune. He awards and honors FMC Gold Medal in 2020, Lieutenant Colonel D.S. Gulati Memorial Gold Medal 2020, Vice Chancellor Center Merit 2020, Life Fellow Addiction Psychiatry Society of India, Life Fellow World Association of Psychological Rehabilitation in chapter, Life Fellow Indian Association of Geriatric Mental Health. Areas of interest, relapse in alcohol use disorders, treatment-resistant depression, benzodiazepine refractory delirium tremens, anxiety disorders. Research publications and next one, please. Research publication and book chapters, 22 research publications in various national journals. Reviewers, Springer Nature, IJPP, Industrial Psychiatry Journal. Dr. Alim, Pinner me.
Yeah, I think Dr. Manira has a started screen share, so.
And his reviewer, Springer Nature. And over to the chairpersons to take over this meeting. And one will introduce Dr. Manira Rasamna. And I request Dr. Gaur to introduce her. And both the chairpersons to kindly throw some light on the topic of the day. Over to the chairperson. Kindly take over.
Thank you, Tufan Pati sir. At the outset, I thank Thursday Musings team, particularly Series Chairman Tufan Patti sir, Alim Siddiqui sir, Amrit Patjoshi sir, Shobit Garg sir, and Dr. Vishal Chabra sir for having us here. And this has been a long running series over the last 6 years, if I'm not wrong. It started during the COVID time, and I don't remember missing out on any weeks hardly. So, and what it has done is it has joined the psychiatrists across the nation and various specialities, and it has helped us liaise better with other specialities also, and even sports persons, movie, film fraternities. So this is one platform. So thank you, Tufan Patti sir and the team for this magnanimous series. And today's topic, that is hypertension, what psychiatrists need to know. As we all know, that it is a most coexisting condition that we have to deal with in our day-to-day practice. The age group and nowadays even the younger people are also coming up with hypertension. The management aspects and all these things, I'm sure today's speaker, Dr. Manira Daswana. I would request my co-chair, Dr. Rajit, to introduce the today's speaker, and then we can proceed with the talk.
Thank you, sir. Am I audible, sir?
Yes, Dr. Rajit.
Right. So first of all, thank you very much to Dr. Tufan Patti sir, Dr. Alim Siddiqui sir, Dr. Amrit Patjoshi sir, and Dr. Shobit Garg and Dr. Vishal Chavda sir for giving us this opportunity to chair this session. It would have been incomplete to know hypertension as the series is progressing from diabetes now to hypertension. So we have today this topic. We all know that hypertension itself has now got a new hypothesis of neuroinflammation. Other than that, all the antihypertensive agents, may it be amlodipine and all calcium channel blockers, we know that they have been associated with some depressive symptoms. So with all these background, one is the illness itself, and other are the drugs itself having the psychotropic side effects. We have today Dr. Manira Dhasmana with us. Dr. Manira is a graduate of SMV Medical College, Pondicherry, MD Medicine from Shri Mahantesh Indresh Hospital. She has accolades of being the senior resident at AIMS Rishikesh, and now she is working as a consultant in internal medicine at Max Dehradun. She has got a fellowship in rheumatology. So with this background, I will now request Dr. Manira to please start her presentation. Thank you very much.
Sir, can you see my slides?
No, Dr. Manir, you have to share because we were sharing the introduction slides.
Okay.
So you can try and share once. Unshare and then reshare.
Yes.
There is this share button. Can you click?
Yes, sir.
Yeah.
But वो click करके कुछ हो नहीं रहा है, वो hang हो जा रहा है. That's an issue.
I think, sir, then I'll share, sir. Yeah. Dr. Manira, I think your
Yes,
slides are visible, and you can actually tell me next. So I'll go to the next slide.
Yes.
We
So
can
good
start
evening,
now.
sir. Dr. Manira Dasmana, and it is a true honor for me to present. And thank you so much, Shobit Garg sir, for giving me this opportunity today. So, management of hypertension, what a psychiatrist should know, and definitely what a GP and a practitioner should also know. Next. Next, please. Yes. So, as per the 2024 guidelines, I have taken the NICE guidelines, the American Heart Association guidelines, and plus the JNC guidelines. They have made it very simple for us now that they say that the office systolic blood pressure of more than 140 and diastolic office blood pressure of more than 90 is hypertension. And now, what is new in this? Now there's a new BP category that has been evolved, that is elevated BP, which does not mean that you have hypertension, which means that you have an office blood pressure of 120 to 139 and a diastolic blood pressure of 70 to 89. I'll tell you the importance of these points in my later slides. Next. So the persistently high BP in systemic arteries, it is a hallmark of hypertension. And what is important is that it is a modifiable risk factor now. And most patients with hypertension, they have essential or primary hypertension, which means that there is no cause of hypertension in such patients. But 10% of patients, they have secondary, and in India, the most common cause of secondary hypertension is CKD. Next. So this is the JNC classification, which has been going on since 2007, and it has been the new guidelines still have to come, but this tells us stage 1, 2, and 3. So stage 1 is if the systolic blood pressure, clinic blood pressure is between 140 to 159, and the diastolic is between 90 to 99. Now, one very important term that has been which has been introduced now is, which we are giving a lot of focus on to, is ABPM and home. That means an ambulatory blood pressure monitoring and home blood pressure monitoring. So if the ABPM is, the systolic is between 135 to 149 and the diastolic in ABPM or HBPM is 85 to 94, we can see that both the values are different, which is of a lot of significance. Stage 2 is if a patient comes to me in the clinic and the blood pressure is between 160, systolic is between 160 to 180 and diastolic is between 100 to 120. But what does, if I send the patient at home, or if I ask the patient to do ambulatory BP blood pressure monitoring, then simple. If the systolic is more than 150 or the diastolic is more than 95. And stage 3 is if the systolic is more than 180 and the diastolic is more than 120. And usually such patients we always refer to the emergency rather than taking care of them at the clinic. Next, please. So these are some modifiable and non-modifiable risk factors, and in which the most important thing that, as in psychologically and psychiatry point of view, I'll be focusing on is behavioral factors. We can see that the renal mechanism, hormonal mechanisms, and vascular mechanism that takes place in especially in a place like India. What we need to know is the renal mechanism and the behavioral factors, because these are the ones that which are most important. Next. So what are the effects of high blood pressure on the system? In the eye, we know it is hypertensive macrovasculopathy or retinopathy. In the brain, we'll have white matter lesion, or the patient will come with microbleeds or stroke and vascular dementia. Large and medium artery atherosclerosis can also be a thing. And plus, for this, what we do is we calculate an ASCVD score that I'll be talking about in the later slides. And endothelial dysfunction especially in young patients, is the most important thing that we need to take care of. And kidney, if the kidneys are compromised, then there'll be glomerular arterial hypertension and there'll be glomerulosclerosis. Whereas in heart, the most important thing when the patient comes to us in the OPD for the first time, we get the echo done, we'll find that the patient is having LVH. What will left ventricular hypertrophy tell us? That the patient is having blood pressure from a very long time, because LVH always takes time to develop. Next, please. So these are some pertinent definitions. Like, if, for example, a patient comes to me in the OPD and the patient has, or your OPD, and the patient has a blood pressure of 150 by 100, and blindly we start the patient on any ACE or ARB inhibitors. Like telmisartan, for example, is a very most common drug, and we give that patient, she's a 45 years old female, and we give her 40 milligram OD dose. After 1 week, she comes to me, she's not happy with me, and she complains that, whenever she's getting up from the bed or getting up from sitting position, she's having dizziness and she's having vertigo. So that is why these definitions come in place. First thing is postural or orthostatic hypotension, which means that increase in systolic blood pressure of more than 20 and diastolic pressure of more than 10 after we make a patient stand from lying down position for a total interval of 5 minutes. That means we take the patient's BP first in lying down position, then we ask the patient to stand, and after 3 to 5 minutes, we again take the patient's BP. If the SBP is, it has fallen by 20 mmHg, and if the diastolic pressure has fallen by 10, that means the patient is having orthostatic hypotension, and there are a lot of drugs which are contraindicated in such conditions. The other thing is that you people face a lot, that is white coat hypertension. A patient is sitting outside your OPD and the staff is taking the BP, and his BP is 150 by 90. He comes to us in the OPD and he tells that, ma'am, जब भी मैं OPD में आता हूँ, hospital आता हूँ, तब मेरा BP बढ़ता है. Otherwise, I'm okay. Why am I telling this point is that from psychology and psychiatry point of view, 40% of patients of anxiety neurosis have white collar hypertension concomitantly, and we need to know that there is no need for treating it. And then masked hypertension, exactly vice versa. That means in office the patient's BP is completely fine, but at home his BP recordings are high. Next, please. So what is a take home message? That we do not start antihypertensives on first visit except in patients with hypertensive emergencies. That means the patient has a BP of 180 more than 160 and diastolics more than 100. So we have to follow two approaches instead, which now JNC guidelines, American Heart Association have said that it is mandatory. If any patient who's coming to us in the OPD, we have to ask the patient for at least these two things. One is home BP measurement, right, which is an out of office approach, and the other thing is ambulatory BP measurement. The only difference is that ambulatory BP measurement will take care of it by measuring the BP at set intervals and using an oscillometric device at home. Next, please. So if we have this diagram in hand, then believe me, we don't even need to go to the management of hypertension, because now that it is clear that if the patient is coming to us for the first time diagnosed as hypertension, if he has elevated BP, then these are the only steps that we have to follow. The first step, it is not possible at all in the hospital setting. That is, if a patient comes to me with a high BP of more than 130 and diastolic 90, I have to ask him to be seated comfortably and again measure the BP after 5 minutes, because hospital, it is not a really quiet environment. Then the second thing is that there's a use, obviously hospital use a validated device and with an appropriate cuff, because if a patient has come with morbid obesity and if you're using a short cuff, definitely the BP is going to be wrong in that. And we have to place the BP cuff at the level of the heart. Then, as I've told you before, we have to assess for orthostatic hypotension at the clinic, and we have to measure the BP 3 times, 1 to 2 minutes apart, and at least we should have average 2 to 3 readings. Then we have to record the heart rate also, because if the patient is having irregular heart rate, then we cannot start any BP medication. We have to ask the patient to do Holter monitoring, and plus we have to ask the patient to do ABPM. And then we have to measure the BP in both the arms. Again, a very, very important practice which no one does these days. And we have to obtain further measurements if the readings differ by 1 mmHg. That means if the patient has come to my OPD and again after 5 minutes intervals I'm doing the blood pressure, and first it was 150, now it has come 140, that means again it can be a sign of white collar hypertension. Next, please. Now, just to give you a gist of ambulatory blood pressure management, because these days this is a very, very famous practice, and almost all the cardiologists are referring their patients for ABPM. So we have to use a validated BP device, and this device usually records BP at the interval of 15 to 30 minutes. Why this is so helpful? Because the patient can just go at home, relax, do the day-to-day activities, and then after 24 hours, it will give a proper reading of 15 to 30 minutes apart, and plus it can also catch a lot of arrhythmias. So a minimum of 70% unusable BP recordings is required. And again, ABPM, we know the guidelines are completely different in JNC also. That means the BP should, if it's more than 130 to 80 mmHg over 24 hours, or if we take out the average of 24 hours, if it is more than 135 to 85, then maybe we can start the hypertensive to this patient. Next, please. So this is the comparison of, this is not JNC, this is American Heart Association, which was, their guidelines came out in the last year, that is 2024. And I found this slide very good, because I'll tell you why. They have done a daytime and nighttime ABPM measurement also. So as we can see, a non-elevated BP in offices, if it's less than 120 to 70, elevated it if it's between, systolic is 120 to 140, and diastolic is 70 to 90. Whereas hypertension, if it's more than 140 by 90. Now, home BP, exactly, it is different. In home also, it's not 140 systolic blood pressure. If it is between 120 to 135. Why? Because at home you're in a silent environment. So if systolic is between 120 to 135 and diastolic is between 70 to 85. And hypertension, if it's more than 135 to 85 at home. Daytime BP is supposed to be higher than nighttime BP. As you can see in hypertension, daytime BP, if it is more than 135 to 85, then only we have to start antihypertensive. But if in nighttime, if it is more than 120 to 70, then in nighttime also we have to start antihypertensives. Why? This also I'll tell you in the later slides. Next, please. So out of the pathophysiology of hypertension, the most important things that I'm going to focus right now is socioeconomic and psychosocial factors, behavioral factors, and sleep. Next, please. Socioeconomic and psychosocial factors, like low socioeconomic status is associated with the increased hypertension prevalence, and there are several mechanisms have been identified, such as there is disparities in the material circumstances, or there is socioeconomic deprivation, there is health behaviors or psychosocial stressors. Psychosocial stressors, they promote increased BP through direct biological effects, like there'll be increase in the or activation in the sympathetic nervous system, and there'll be increase in pro-inflammatory factors. So we see patient of such background will always have increase in ESR, CRP also, but also through socioeconomic, environmental, and behavioral risk factors, like they're having a very poor and unhealthy lifestyle. Then gender and ethnicity. Now in 2024 guidelines, it is seen that females suffer the risk of ASCVD more than males, and like because they have more psychosocial stress, there is more discrimination and even ethnicity. Next, please. So affective and behavioral disorders, there is an increased risk of hypertension that has been described in patients with affective disorders, and the burden of vascular risk factors including hypertension has been suggested to drive depressive symptoms in aging through microvascular brain damage or white matter lesions. And behavioral factors such as physical inactivity, smoking, excess of alcohol consumption, unhealthy dietary habits, or diets favoring high sodium, low potassium, and unlimited fruit and vegetable intake is in developing and maintaining hypertension. Next, please. So sleep disorders, both short sleep duration and poor sleep quality have been associated with high BP, and sleep loss and fragmentation induce dysregulation of neuroendocrine pathways, adrenergic pathways, and pro-inflammatory factors, and this also leads in increase in sympathetic activation. And especially in patients with obstructive sleep apnea, there are repetitive hypoxic episodes at night that additionally contribute to sympathetic activation. Next, please. Now, this is a very important point, that what if elevated BP is good for us, and especially in psychiatric patients, because the positive effect of high blood pressure on mood might be related to research findings showing that higher blood pressure is diminishing emotional experience. In there was an experimental manipulation, but we found it out that it is also well established that elevated blood pressure robustly reduces the perception of physical pain, but also social pain. It has therefore been hypothesized that elevated blood pressure relates to generalized attenuation of emotional valence and processing. And how does it do that? Because it involves the baroreflex system, but there are no as such human studies done on that. Next, please. So before starting any antihypertensive, I would like to calculate an ASCVD score, and especially all the cardiologists, they always like to calculate ASCVD score. And a scoring system of less than 10 usually signifies that the patient has a very insignificant risk. Next, please. So this is a 10 years ASCVD score, and it is very easy. We usually don't have to mug it up. We have a calculators for that, and it shows us that if it's low risk, it's less than 5%, and borderline is 5 to 7.4%, intermediate is 7.5 to 19.9%, and high risk is more than 20%. So why am I sharing this slide with you? Because usually cardiologists and us, we start antihypertensive and we explain to the patient, we take this out and we explain to the patient, if the patient is borderline, that is, the patient risk score comes to be more than 7.4%, definitely the patient should be on antihypertensives. Next, please. So these are the routine tests recommended in the initial workup of the patient. That means if the patient comes up to you and he has elevated blood pressure, honestly, even if the patient has white collar hypertension, office hypertension, definitely once in a lifetime or once a time with the patient is coming to you, we should assess all these things. That is fasting blood glucose level with HbA1c, serum lipids, in which the most important thing is cholesterol and LDL cholesterol, plus HDL also. The serum sodium potassium level. Why? Because it will tell us two things. If we have to start a antihypertensive, which one should we start? Because if the potassium of the patient is high, there are a lot of antihypertensives that we cannot start. And same thing goes for sodium. If the sodium of the patient is low, like thiazide diuretics, we cannot start on the patient. And then blood creatinine level, EGFR of the patient, urine analysis, especially in young patient, urine albumin to creatinine ratio, and a 12-lead ECG. Next, please. So what is a non-pharmacological treatment? I will just give you a gist of it. Usually what we tell the patient is, sir, ऊपर का नमक नहीं खाना है. Now, if you tell the patient that, आपको 2 ग्राम दिन में नमक नहीं खाना है, the patient is going to be confused. So what we try to tell him is that at least you, in the whole day, in 24 hours, you have to just have 1 teaspoon of salt in 24 hours. And what do I mean by ऊपर का नमक? That means all these things, raita, dahi, papad, achar, that is ऊपर का नमक, which contains more sodium. So this is what the patient has to completely avoid. And moderate intensity aerobic exercise. In 2024 guidelines also, the change is that we just don't ask the patient to do brisk exercises or run. We also ask the patient to do dynamic and isometric exercises, like moderate to minimum weightlifting exercises. Next, please. And this is known as resistant training. So although this is very obsolete for me, we never tell the patient to maintain the BMI to 20 to 25, although waist circumference plays a very important role, which is less than 90 centimeter in men and less than 80 centimeter in women. So this is very important. Then adopting a very healthy lifestyle and balanced diet. 2 diets are very famous in hypertension, although there are many diets, but DASH diet and Mediterranean diet. What is the difference between these 2 diets? Mediterranean diet allows us to have healthy fats, but DASH diet only allows us to have green leafy vegetables, and as far as fats are concerned, even fats are less. And both DASH diet and Mediterranean diet, so I have a DASH diet and Mediterranean diet paper in my OPD, which I just have to give to the patient. The patient goes at home and reads it. And men and women are recommended to drink less alcohol, right, which is about 100 grams per week of pure alcohol. How this translated to number of drinks depends upon the portion of size and the standard of which it differs from country to country. But most drinks, they contains 8 to 14 grams of alcohol per drink, that is per 30 ml. Next, please. So it is recommended to restrict free sugar consumption also, which is in particular sugar sweetening beverages, to maximum of 10% of energy intake. It is also recommended to discourage consumption of sugar sweetened beverages such as soft drink, fruit juices, and especially at a young age. Next, please. And it is recommended to stop tobacco smoking, to initiate supportive care, and to refer smoking cessation programs, as tobacco is a strongly independent risk factor for CVD events and all cause mortality. Next, please. So these are the pharmacological intervention, and I start with my favorite drug, that is ACE inhibitor and ARB inhibitors. So we know ACE inhibitors, there is captopril, lisinopril, lisinopril, ramipril, and perindopril, and all these are in OD formulation, that means once a day formulation, except for captopril that comes in twice a day formulation. Then we have angiotensin receptor blockers, that is candesartan, losartan, olmesartan, telmisartan, and a new drug, azilsartan, that I would like to speak something about. And then calcium channel blockers, we have 2, dihydropyridines and non-dihydropyridines. Dihydropyridines, the most famous drug used for years and years together, has been amlodipine. But in my OPD practice, I have decreased the use of amlodipine. I'll tell you why. And then it is phenodipine, there is nifedipine. Nifedipine we only keep for patients who are trying to conceive or are already pregnant. Otherwise, in normal general population, we will not give it. Diuretics, thiazide diuretics, now again coming into the streamline, chlorthalidone and hydrochlorothiazide and indapamide, and potassium sparing diuretics, which are now the most robust second line treatment, which is epinephrine. Beta blockers, we now know they are selective and cardioselective and non-cardioselective beta blockers. Again, as amlodipine, atenolol also used for years and years together, but now we have very newer type of beta blockers like carvedilol and bisoprolol that I'll be talking about. Next, please. We have another class drug, that is alpha blockers, which is prazosin and terazosin. We use a lot, but if a patient comes to me for the first time in the OPD, I would never start these drugs. Next, please. And loop diuretics. Loop diuretics used everywhere, especially in CKD patients, furosemide, torsemide. Calcium channel blockers, again, non-dihydropyridines like diltiazem and verapamil. Vasodilators like minoxidil and hydralazine, and centrally acting hypertensives like clonidine, methyl dopa, and moxonidine. Now, again, the same thing, vasodilators and central acting hypertensive would never be my first drug of choice if a patient comes to me in the OPD for the first time. Next, please. And choice of antihypertensive in various disorder. This is a very, very important slide. Again, published by both JNC and American Heart Association and even European guide journals. This is in diabetes mellitus and metabolic syndrome. The first drug of choice would be ACE inhibitors. In chronic kidney disease, it will be ACE inhibitors, and especially if a patient comes to us with proteinuria and albuminuria, or his urine albumin creatinine ratio is high, then definitely I'm going to go for ARBs or diuretic. My second choice would be calcium channel blockers and SGLT2 inhibitors. Post myocardial infarction, I have to add the patient on beta blocker, and that too cardio selective beta blocker. If my patient has atrial fibrillation, I would like to add a beta blocker with ACE or ARB. If my patient has ACE, if my patient has heart failure, definitely ACE inhibitor. Plus, I would like to add SGLT2 inhibitor that I'm adding in all of my patients in the OPD. Next slide, please. Okay, again, a very important slide. Contraindication of antihypertensive as a general practitioner, as a psychiatrist, as an MD medicine. This slide is something that I should know by heart. That is, what are the absolute contraindication of ACE inhibitors, what are the special precautions that we have to take. So ACE inhibitor, the absolute contraindication is pregnancy, and even if a female comes to you in the OPD and she wants to conceive, absolute contraindication. And then if she already had an edema in the past, if we have seen her serial reports and the potassium level was always found to be above 5, not even 5.5, in Indian population more than 5, and if the patient is a patient of bilateral severe renal artery stenosis, and so I would not like to start. It's an absolute contraindication, right? And again, I told you special precaution, women in childbearing age, I would never start. ARB, again the same thing. Pregnancy, hyperkalemia, and bilateral renal artery stenosis. Calcium channel blockers, very important, especially dihydropyridines. They always cause reflex tachyarrhythmias. So if a female, we write calcium channel blockers, she wants to conceive in the future. But again, if a female's after starting dihydropyridine, she complains of ghabrahat, she complains of palpitation, then we have to stop this. And special precautions we have to take in heart failure. Then, if especially the patient has any pre-existing leg edema, as we know, amlodipine. Now, what I was telling you before, why I don't prefer amlodipine now, because in my lot of patients come to me with the complaints of leg edema if I start amlodipine. And then there is non-dihydropyridines, and if a patient is a patient of sinoatrial block, or the patient already has a pacemaker implant, I would never start. And especially if the patient has LV dysfunction, that means if his EF is less than 40%, I would never start a non-dihydropyridine. Diuretic, thiazide diuretics, the only absolute contraindication is if the patient has active gout. That means if he has trophy pigment in his legs or thumb, then I would never start it. And then the other thing is if the patient has metabolic syndrome, because there are a lot of studies that have shown that thiazide diuretics also cause increase in cholesterol levels. If there is glucose intolerance, why? Because thiazide diuretics in some studies have shown that it causes insulin resistance. Again, pregnancy, I would not like to start diuretics. And three things, that is, they will cause increase in calcium, and they will cause increase in potassium and increase in sodium. So especially if a very frail patient comes to you, he's more than 60 years of age, and he gives you a history of having low sodium levels, thiazide diuretics will never be my, not even thiazide diuretics will never be my first choice of drug. And then it is beta blockers. Beta blockers, if especially if you're not using a cardio selective one, then if the patient is of acute asthma exacerbation, or if there's a sinoatrial block patient, I will never use beta blockers. Asthma patient, again, metabolic syndrome and glucose intolerance. As we know, beta blockers will mask the symptoms of hypoglycemia. So this is another reason that in diabetic patients we never use beta blockers unless we have a patient of myocardial infarction, because after MI and especially post PTCA, beta blockers have a very good role. Next, please. So this is the only slide in which I'll be talking about centrally acting antihypertensive like alpha blockers, and especially from a psychiatric point of view also, because alpha blockers are centrally acting hypertensives. They are no longer recommended for the treatment of hypertension unless all the other agents are contraindicated or no agent is working on the patient. Centrally acting antihypertensive and alpha blockers increase the risk of falls. through a variety of mechanisms, like principally by increasing the risk of hypotension, increasing the risk of orthostatic hypotension, increasing the risk of arrhythmia, and increasing the risk of sedations. So definitely, if a psychiatric patient is there and you have put him on multiple sedatives, then I would never suggest centrally acting antihypertensives in such patients. And for the centrally acting hypertensives, heart block and sick sinus syndrome are absolute contraindication, especially clonidine, that is arcamine, that we very after if a patient is of resistant hypertension, we write arcamine a lot. For methyl dopa, depression should act as a contraindication, as well as rarer problems also, such as we have porphyria, paraganglioma, and pheochromocytomia. Methyl dopa, it's an absolute contraindication. And drug-to-drug interaction are common for methyl dopa, with a higher risk of hypotension reported with if it's used in conjunction with antihypertensive or other medications which cause hypotension effects like antipsychotics. So now, moxonidine and clonidine have similar issues, but also have a potential to increase risk of drowsiness, confusion, and CNS depression if used in conjunction with other neuroactive medications also. Next, please. Okay, so this slide I've already told you that my go-to drug will be ACE inhibitor, and if I see that the most robust effective drugs are ACE, ARBs, dihydropyridine, CCBs, diuretics, and then beta blockers, and this is the way I even started. And the first four are recommended as a first line of treatment, and the other thing is that beta blockers can be added preferentially in circumstances such as presence of angina or heart failure after myocardial infarction, and where they are the cornerstone of therapy. In such settings, second generation can also cardioselective can be added, or third generation which have vasodilating effects, beta blockers can be added, like caripin. Like your cardioselective like bisoprolol and carvedilol. They are the best. Then, however, beta blockers are less effective than ACE inhibitors, ARB, and calcium channel blockers or diuretics at preventing stroke. So if a old age patient comes to me, and or if a 45 years old male comes to me and he has a family history of stroke, the first drug I will never go for a beta blocker. And the effect of RAS blockers and CCB on preventing progression of HMOD also appears to be superior to beta blocker. So we have to remember that organ damage, RAS blockers and CCB, I think so, they are much better. Then beta blocker should be avoided in patients with isolated systolic hypertension, or more generally with arterial stiffness, as they increase stroke value. That is, they'll decrease the heart rate. As they'll decrease the heart rate, they'll increase the stroke volume. Next, please. Resistant hypertension, the only thing that we have to remember in this is that at least these, we have tried thiazide diuretics, or we have tried diuretics, we have given a RAS blocker, and we have a calcium channel blocker. Still, the office or systolic and diastolic blood pressure is more than 140/90. That means the patient is having resistant hypertension. And if every therapy fails, then we can add a beta blocker, or we can add a potassium sparing diuretics, that is spironolactone. Next, please. Now, isolated systolic and diastolic hypertension, this is one thing that has only been added in the European guidelines, and I find this slide very important. JNC is still very dicey about it, but we see so many patients in OPD with this. That is, the patient will only have a systolic blood pressure of more than 40, but diastolic blood pressure will be more than 90. So this is isolated systolic hypertension, and it is most common in older patients. Why? Because obviously, as we grow old, the vessels, they become stiff, and there is decreased arterial compliance. And the first in this, the drug of choice will be calcium channel blockers and thiazide, not ACE inhibitors, not ARB inhibitors. I would also like to say one point. There's a new drug that I was talking about, azilsartan. Azilsartan is very effective in patients with isolated systolic hypertension, which comes in the category of ACE inhibitors. Then drug to avoid is beta blocker. You cannot give the patient beta blocker in isolated systolic hypertension. Then diastolic, exactly the same thing. Whenever we are checking the systolic blood pressure, or I ask the patient to check the blood pressure at office or home-based monitor, the systolic blood pressure is always less than 40, but the diastolic is always 90. Now we have to be very careful, because it is seen mostly in younger patients, and especially in adults with obesity. And treatment, the first focus should be on lifestyle modification, not on any drug. And if I tell you about isolated systolic and diastolic, but which is more dangerous, definitely isolated systolic hypertension is more dangerous, and it causes more end organ damage. Next, please. So drug interaction, although to be very honest, uh, from psychiatry point of view, I would say that I'm very weak in it, because I'll have to go through all the psychiatric medications to find out. But what I could find out from the previous articles, I took out some studies, and a potential of drug to drug interaction increases with raising age, since elderly patients receive a large number of drugs. So, but also because the renal excretion of several therapeutic agents is impaired in elderly patients as a result of diminishing kidney function. So several drugs are subjected to inactivation via metabolic degradation of liver and catalyzed by various enzymes. A comparable but opposite problem is an inhibition of liver enzymes involved in the biotransformation by a variety of drugs such as cimetidine, erythromycin, metronidazole, tricyclic antidepressants, phenothiazine neuroleptics, and sulfonamides. So enzyme inhibitors of this type impair the biodegradation of certain drugs and hence increase their effects. And certain drugs may impair with renal secretion of other agents. Only 2 studies are done in this. That is usually at a renal tubular level. For example, thiazide diuretics may deaccelerate the renal elimination of lithium salts and hence reinforce their toxicity. So this is one thing that we have to remember, that I think so patient on lithium, we should not give thiazide diuretics. Next, please. And some other studies that I found was chlorpromazine with captopril, clozapine with enalapril, beta blockers. Sometimes if you go to a psychiatrist, then they might give you Ciplar-LA or propranolol 20 milligram they'll start with. And plus, if you'll see the cardiologist paper also, the patient would be a patient of CAD and would be started on beta blockers. So what is the problem with this? They will all cause, if they are given in combination, they will all cause orthostatic hypotension. And again, if you're giving clozapine with ACE inhibitors, we have to evaluate the white blood cell count of the patient and electrolyte periodically, because ACE inhibitors and clozapine will increase the potassium levels. And but how much I could understand, that there is no absolute contraindication for using any hypertensive with any antipsychotics. So in terms of drug interaction, which calcium channel blocker I would say it's famous and it's very effective is nebivolol, because I have never found with any such side effect with nebivolol. And we can see that even for all these drug that I've written, we have to check the electrolyte level, because somehow electrolyte disbalance would be there in every drug. Next slide, please. So I have just given some case scenarios, and these are my just last few slides, because case scenario leads us to the better understanding of hypertension management. There's a 40-year female. She has no past medical history. She comes to me for a routine health checkup, and her vital is 138/90. Her BMI is 27. Her height is 5.5. Her menstrual cycle was 2 weeks back, and her cycles are very regular. Now total cholesterol is 215, increased. LDS is increased 125. HDL is 35. She's a Caucasian, and her mom had MI at the age of 49. Patient had some high recordings in the past, but she did not follow up. She eats fast food 2 to 3 times a day and at least 4 times a week. And she has a very sedentary lifestyle. She does not work out. She's a non-smoker. So, does this patient have hypertension? That is the first thing. If she has hypertension, does she warrant medication? So, the first point, the answer is in the first slide. That means you can never diagnose a patient with hypertension if she comes to you for the first time in the OPD. You have to ask the patient, if she cannot afford the ambulatory BP monitoring because it's quite costly, then you have to ask her to monitor the BP at home, and then a 7 days chart she'll come and she'll show to you. If then it falls under the JNC criteria, then we'll start the medication, otherwise we'll not. So again, does she warrant medication? If she comes to us with the monitoring, and yes, we find out that the ABPM or HM is more than the required criteria, then we'll start. If medication is warranted based on her presentation, does she have any compelling indication of key factor to consider when choosing a medication? Yes, but for this patient we don't have anything, because she has just come to us for the first time. So next slide, please. So that is why this slide is only about ABPM and HBPM, because again, I'm repeating, we always have to tell the patient, go home and monitor your BP, or at least just put the ABPM device. Just one monitor, one reading, it will not tell us anything. Next slide, please. So treatment of hypertension, this is a chart that I always keep in my OPD, and we can see it was in 2017 guideline, but this chart still stands robust because it's a very important thing. Whenever a patient will come to my OPD, this is how I'll evaluate the patient, and this has also been made from JNC only. Next slide, please. And this is JNC 8 hypertension guideline algorithm. I would just like to go through that, and it is very easy. We can see that if the age is more than 60 years and if the age is less than 60 years, this is general population. So the BP goal, we have to remember, if the age is more than 60 years, the BP goal should be less than 150/90. So please don't try to reduce the BP very fast. And if it is age is less than 60 years, then the BP goal is less than 140/90. The green chart only shows us the patient who do not have diabetes, who do not have CKD. Then if the patient is of any age, right, and if diabetes is present but there is no CKD, then again the goal is less than 140/90. And if all ages, if the patient is of any age, has CKD with or without diabetes, again the goal is less than 140/90. So what do we understand by this chart? That if a patient comes to you with no diabetes and no CKD and the age is more than 60 years, then the BP goal should be 140/90, 150/90, and not 140/90. And the other thing that we'll see is that we can see in the JNC criteria that they have seen the ethnicity and the race also. That means black and non-black. So if the race is black, then they are initiating the first choice of drugs is thiazides and CCB. And if it's non-black, then the first drug of choice is thiazides and ACE and ARB inhibitors, which is very important point. In India also, these days, we are as first drug of choice. If there are no contraindications, we are starting with calcium channel blockers and thiazide diuretics. Their effect is very good with less contraindications. And now the other thing is that about at the if the blood pressure goal is achieved, if the blood pressure goal is achieved, is good. If it's not achieved, then what we'll do is we can always add another antihypertensive, or what we can do is we can increase the dose of the previous antihypertensives that we have been taken. So this is very important. And the other thing is the initial choice of drug. It is given in the upper corner also in the pink box that the first initial drug of choice for hypertension will always be ACE inhibitors. The next will be angiotensin receptor blocker. Third will be diuretics, and the fourth will be calcium channel blockers. And this is how I go about in my OPD. Except I've told you, if the potassium level is high, or if there's a patient of CKD, or if the patient is renal artery stenosis, then my first choice is always ACB and ARB. Next slide, please. Now, what is the problem? The patient never returned to me in the OPD. I told her that she has to make some lifestyle modifications, and I told her to do HBPM, but she was lost to follow up. That what she did was she did some BP recordings at home, and she saw that her BP was always systolic was always between 140/48 to 50, and diastolic was always above 90. And BP clinic, when I measured, it was 150/95. So she attempted lifestyle changes, but she was not successful in it. She has gained weight also now, and then she complains of frequent urination, fatigue, and thirst also. And now she's on depomedrol because she's now planning for pregnancy after a year. So what is my next step? Obviously, because the patient is now showing symptoms, I would like to do labs. Now her sugar comes out to be more than 250, her HbA1c 6.9, and you can see that her cholesterol has increased now. Next, please. So next, please. This is just a slide that we have to remember, because in every patient we have to put this slide. Next, please. So now she's in, according to JNC guidelines, she's in stage 1 hypertension, no CVD risk. Why? Because I've already calculated her ASCVD risk calculator, and it came out to be less than 7.4. So, but now patient has progressed to stage 2 with subsequent development of diabetes and high cholesterol. So based on her increased ASCVD risk score, which was previously less than 7.2%, but now it is more than 7.4%, she is a candidate for medication. So lisinopril or CCB are first recommended, and I would like to give her that because she's on depot. So if she's planning for pregnancy, I would not like to start on ACE and ARBs. If she was not planning for pregnancy, my first choice would have been ACE and ARB. And special consideration, definitely we have to take for women with childbearing age, and that is why I'm starting around calcium channel blockers. Next, please. Again, case 2, which is my last case, female, past history of some kidney problems that she doesn't know, and she has just presented to me with the annual examination. BP is 170/90, but she denies any symptoms. She has high BP in the past. She was on medication, but she has been out of it for months. She does not recall the name of the medication. She feels fine today. Her BMI is normal. And again, past medical history, she gives history of kidney issues and arthritis. So you can see I've added arthritis in it. Why? Because she's taking medications very regularly, like paracetamol and ibuprofen. So family history, mom was on dialysis prior to her death, and sibling had 2 stents at the age of 49. She's unemployed and her creatinine level is 1.6. Next, please. So after 6 weeks, she has no home BP log. She has been taking her medication and BP. No, I'm sorry. So what will I start her on? That is the first thing. I calculate her ASCVD score. I tell her to take her BP recordings at home. She comes back to me. Her BP recordings are increased. So for her, I started her on a ACE inhibitor because everything was looking fine. She has completed her family. So, and plus because the serum creatinine was 1.6 and she had proteinuria, I started her on ACE inhibitors. Then 6 weeks, I call her for a follow up. So there has been no home BP log, but has been taking a medication properly. The BP in the clinic today is 150 by 90, and labs return to creatinine level of 1.6 and potassium of 4.5, which is the upper normal limit. Now what will I do? Definitely, I told you that ACE inhibitor contraindication is that there should not be any increase in creatinine level. There should not be any increase in potassium. Her potassium has gone high from the first reading. So what I do is now thiazide like diuretics is a very good choice for me. Why? Because I've already told you that thiazide like diuretics will decrease the potassium level, and plus they'll benefit from potassium wasting also. And then if I don't want to start thiazide diuretics in this patient, my go-to drug will be calcium channel blocker, especially cilindipine. Next slide, please. After 4 weeks, she again comes to me. I've started thiazide like diuretics. Her BP has improved and she has lost 5 pounds. Now we have to review her medicine list, and she shows that she continues to be on paracetamol and ibuprofen for her arthritis. Although we have told her that she needs to stop it. Why is this slide important? Because a lot of patients will come to us in the OPD, and we have to find out there are certain drugs that contribute to elevated blood pressure, like non-steroidal, that is COX-2 inhibitors, then sympathomimetic drugs like or appetite suppressants, oral contraceptive, corticosteroids, cyclosporin, tacrolimus, and erythropoietin, and cocaine and amphetamines. All these things, they will increase blood pressure. So even if you're giving a blood pressure medication to that, and if the patient is not getting rid of this, then nothing will happen. So now I ask the patient to discontinue ibuprofen. Next, please. The patient returns to me in 3 months. She looks great. Her weight is down another 10 pounds, but now she reports of cold for nearly 4 months and has no other URTI symptoms except for dry cough. So now what I'm suspecting is an ACE inhibitor cough. So we need to discontinue ACE inhibitor. What I did was I added a thiazide diuretic with an ACE inhibitors, but now I need to reduce it. So what I do is, if I want, I will still continue thiazide diuretics with a calcium channel blocker. So the current study suggests that these patients can be switched to ARBs also, but honestly, I don't even start ARB. Then I straight away start to calcium channel blockers, and we can also try a combination. Next slide, please. Again, a very important slide, which is my last slide, and which tells us the indication and the agent of choice in different scenarios. Now we can see that diuretics, what we have to monitor, we have to monitor the electrolyte level, and we have to see that the patient is not suffering from metabolic syndrome. ACE inhibitors and ARB inhibitors, they are agents of choice, my first agents of choice, but we have to see that the patient should not have ACE associated dry cough. The patient should not have renal artery stenosis. Beta blocker, again, as I said, they can never be the first line agents because they cause chronic fatigue, they cause decrease in heart rate, and only suited if a patient is of post myocardial infarction on PTCA. Calcium channel blockers, yes. After ACE, if there's any drug that I prefer more, it is calcium channel blocker. Vasodilator drug like hydralazine, again, not my first drug of choice. And centrally acting agents would be my last drug of choice if all with the therapy with all of them have failed. Next, please. Thank you. So I can see I have a lot of questions in the chat.
Thank you, Dr. Manira.
Dr. Manira, yes, it has definitely generated a lot of questions.
Yes, sir.
Yeah. So you gave us a very comprehensive view of what hypertension is and how to go about it. So we'll take the
Yes.
questions first, and then we'll see Question from Dr. Alim Siddiqui, electronic versus mercury device, which comparison, which is better?
So the first question that I can see is patient on lithium and SSRI, which antihypertensive is safer?
No. First question is, very age-old question, which is better to measure, the mercury wala BP or the electronic BP, which is better?
So
Which is-
definitely mercury. Definitely mercury, sir. Because I'll tell you, in a lot of studies also, in JNC criteria also, it is now saying that electronic device it is not that good. And plus, if electronic, what we tell our patients is, sir, कि अगर हम electronic से करें तो आप हमेशा 10 mmHg ऊपर नीचे ही लेके चलें. That is what we tell. So definitely, and sir, now there have been new BP measuring devices. Electronic तो सर अब बिल्कुल ही मतलब बहुत ही obsolete हो
But
गया.
you see when you go to ICU, all the patients
Yes,
are
sir.
trapped in their all electronic monitoring happening.
Yes, sir. Yes. So
Right?
so that is
Is
why
that
we
good? Is
use.
that accurate?
Sir, it is not accurate, and that is why we would do an arterial blood pressure monitoring for such patients. And ICU में तो सर अब हमारा rule बन गया है that we have to do arterial blood pressure monitoring.
Okay.
Yes, sir.
I think Dr. Manira, first of all, congratulations. You took us to our medicine clinics.
Yeah.
Yes, sir.
Okay, Vignesh. So we thought that the story was going on, and I think a lot of us can relate because when we are treating patients, obviously in liaison with our medicine colleagues like you,
Yes, sir.
a very simple thing is like then if mercury blood pressure, the sphygmomanometer is better, so how they'll
Yes,
do
sir.
this monitoring?
So that is the thing. एक तो आपका electronic होता था that has been discontinued now. So there are new BP monitoring device that has come that tells जो अभी सर cuff में आ रहा है आपके arterial cuff monitors. They are very good. They're into use these days, and even in that also, sir, there is a difference of 10 to 5 mmHg. And by which I mean that उसमें ज़्यादा ही दिखाएगा, उसमें कम नहीं दिखाएगा, because of the obsolete practice that patients are doing at home, because they will not keep it at the heart level. So otherwise, sir, the new arterial cuff monitoring blood pressures are very good.
And you said that 1 week of consistent blood pressure home-based monitoring is required to actually stamp someone as having hypertension. So very
Yes,
common
sir.
question which patients ask us is there any particular time to assess hypertension, any particular time of the day, or it should be consistent time every day?
Sir, as I told you about day and night, जो JNC ने अभी आपका include किया है, उसमें आपने देखा होगा the values are also different. So what we tell the patient is actually a very good question, sir, because the first thing is अगर patient is already on an antihypertensive, then we have to monitor the BP before taking antihypertensive. That is the first point. The second thing is, sir, that we always do blood pressure monitoring at home. That will be 12 hours apart. So if a patient is monitoring the BP at 7 a.m., then they have to monitor the BP again at 7 p.m. That is the only way the patient will get 2 BP recordings and which will be correct. Otherwise, they'll not be correct. Yes.
Okay, and because when patients would come to us, we immediately with anxiety and hypertension, other morbidities, we immediately would want to actually start beta blockers, as you said,
Yes,
like
sir.
propranolol, because of it will
Yes.
cut the peripheral effects of the anxiety. So,
Yes,
and
sir.
patient is already on carvedilol or some other beta blocker, and then it becomes very
Yes, sir.
tricky to coordinate with cardiologist or medicine colleagues. So, how to
Yes,
go?
sir.
Can we give a short-term trial of propranolol till our SSRIs take effect, and then
Sir,
taper?
we can, very right, sir. We can definitely give it. The only one absolute contraindication is that the patient should not have COPD and asthma. If the patient is that, then it's an absolute contraindication. Otherwise, there are a lot of patients, sir, that we also start, propranolol to them. Otherwise, the only absolute contraindication is the patient should not have asthma, the patient should not be an active smoker, and the patient should not have COPD. That's it. Otherwise, sir, propranolol can be started on any patient.
Okay.
Yes, sir.
I think other questions from chat box. Pawan sir.
Sir, the question is, Madam, commonly SSRIs lead to hyponatremia in elderly patients with hypertension on antihypertensives. How to manage that? Because we can't prescribe increase in salt.
Yes, sir. So this is very easy. So commonly SSI lead to hyponatremia in elderly patients. So what we have to do is in patients that, as I said, who are very frail patient, who are more than the age of 50 years old, and they are prescribed SSRIs, we just have to remember that we cannot prescribe them thiazide like diuretics. Otherwise, we can start ACE on them, we can start ARBs on them, we can start calcium channel blockers on them. So SSRI patients on SSRIs, to start it, I won't say it's an absolute contraindication. Of thiazide diuretics, we cannot start. That is one thing.
Your take on tolvaptans, like then how to go about starting tolvaptans?
Sir, tolvaptan is a very good drug, especially if a patient comes to you who has CAD with heart failure. Why? Because tolvaptan, now the new studies in 2023 have also told us that apart from increasing the sodium levels also, it helps in heart remodulation also, and plus taking out the water from the body. So tolvaptan definitely, sir, is a go-to drug. But it
Yes, sir.
becomes a bit, yes, sir, it becomes a bit tricky because in India, the most important thing is patient is lost to follow.
Yes.
So, and tolvaptan, sir, we have to decrease the dose and increase the dose very judicially. So, if a patient we give tolvaptan, we start in a decreasing dose of 15 milligram, we say BD or OD, and the patient does not come back to us, then he'll end up in the ICU only. So that is why tolvaptan we never, especially in Indian population, sir, we don't usually start very easily. That's the thing.
Dr. Manina, I was going through some European guidelines. Correct me
Yes,
if
sir.
I'm wrong. They are saying that combination of, and one of the chat box questions in the similar lines, combination antihypertensives are now more recommended than
Yes,
isolated.
sir. Yes, sir. Definitely.
And you also
Yes.
mentioned in your talk. So that
Yes.
is like, start with an ARB, AC, with an
And
Yes,
thyroid.
sir. Yes. Yes, sir, definitely. So if a patient will come to me, sir, the first thing is that how much is the BP? If it's in stage 1, stage 2, or stage 3, definitely, sir, stage 2 hypertension, according to JNC guidelines, you cannot start with a single drug. We have to go with the combination drug. But if he's JNC stage 1 and the BP is low, sir, then I feel that the patient should be started on only one hypertensive. Until and unless if you feel that our dual combination will give us any proven effects of that, if it has better effects. Otherwise, sir, again, honestly, just we start in ARBs and ACE inhibitors, it's a very good drug of choice.
does it make a difference like one drug if you are starting two drugs and two
Yes, sir.
antihypertensives? We should start in the morning, one in the night, or like we can give it together. Does it have any scientific rationale?
No, sir, but it only has, sir, see, it depends upon the half life. Like telmisartan is a half life of, we can say 16 to 20 hours. So telmisartan, that is why we always give an OD dose. But then again, if the patient comes to me in the OPD next, and if this BP is not controlled, especially, sir, again, a very important question. Why? Because all the patient who suffer stroke is that early in the morning. So now again, the not even the JNC, not even the American guidelines, European guidelines have found out that the patient should control the BP more at night rather than in the morning, because stroke chances are more in the morning. So now, so we see in our hospital also, sir, all the cardiologists, they're giving telmisartan and olmesartan or azacitidine in the evening rather than prescribing them in the morning. So definitely, what we do is, sir, I prefer giving telmisartan, olmesartan at 5 p.m. in the evening rather than in the morning, because usually morning high BP recordings are still okay, but high night recordings are they are associated with increased mortality and even then with the increased ASCVD risk.
A very specific question they have asked is, does thiazide diuretics increases serum creatinine levels in context of CKD?
No, sir. Because now we can see that thiazide diuretics very easily, and all the nephrologists, they're giving thiazide diuretics and loop diuretics in CKD patients. Yes.
Vishal sir. Yeah.
Yeah. So I wanted to ask, you talked about beta cap not being used in metabolic syndrome.
Yes, sir. Yes.
But beta cap is our favorite drug. I mean, propranolol is our favorite drug. The brand is beta cap, sorry.
Yes,
But
sir.
our favorite drug, we use it a lot of disorders. Definitely, I check for asthma and if there any block is there. So
Yes, sir.
then we
Yes.
do, for asthma, I don't write anything because I've had bad experiences. Patient having asthma, even though it's 20 milligram. But
Yes, sir.
otherwise, which is is metoprolol better drug than propranolol?
Sir, honestly, from psychology and psychiatry point of view, propranolol is the best drug. There is no comparison, to be very honest, because there are so many patients that we are writing beta cap to, and it has shown very good effects. But the issue, sir, as I said, the only contraindication is that why I said metabolic syndrome is, sir, because an obese patient comes to you who's a borderline diabetic. If we start beta cap on such patients, or even metoprolol for a first choice, sir, it will mask the symptoms of diabetes, and a young patient would never come to know what symptoms he's having. Like in diabetes, usually sweating happens. There's so many things. Sympathetic nervous system will be activated, but beta cap and metoprolol will
Even with 20 mg? Even with 20 mg?
20 mg we can give, but usually the thing is that in obese patients with metabolic syndrome, we usually avoid that drug.
Okay.
I
So
think
basically,
which eye opener is, sir, that we should avoid diuretics and metabolic syndrome, which I think
yeah.
is
Yes,
important.
sir. Yes, yes, sir.
One more thing
So
you said.
this,
One more thing you
yes, sir.
said that, but that's very interesting concept I learned today. Isolated
Yes.
systolic hypertension and
Yes, sir.
isolated
Yes.
diastolic hypertension.
Yes, sir.
I was still under the impression that most of the patients who come with, let's say, 90 BP lower side and other upper side 160, 170 were basically anxious people. And when you start them with antidepressants, benzodiazepines, they calm down, the BP goes down. I was under
Yes,
that
sir.
impression. But today, so just can you put some light on this? Is it possible that it could be a combination of an anxiety? And you also said very interestingly, systolic is more dangerous than diastolic blood pressure.
Yes, sir.
And
Yes.
from my medical school days, almost 3 decades ago, I thought it was the other way around. So those are
That's
very
right.
interesting things. Is that
Yes, sir.
changed or I've forgotten
Sir,
about it?
it has changed now because
Uh-huh.
first diastolic hypertension was supposed to be the most
Yeah.
dangerous one, but now systolic is because sir again जो European guidelines था भी 2024 में ही सारी guidelines change कर दिए तो उसमें they did a very important study and they found out that isolated systolic hypertension was sir one is hypertension that JNC guideline is saying other thing is systolic and the other thing is diastolic. Out of these three, isolated systolic hypertension is actually the most dangerous one because it increases the ASCVD risk score also. And sir, if we'll see now in 2025 in the ASCVD risk score, they're going to add this. Isolated systolic hypertension is going to have some points.
In context of Dr. Manira, like
Yes, sir.
chat box question and what Dr. Vishal sir is also trying to ask is patient comes
Yes,
to
sir.
us with anxiety
Yes,
and
sir.
elevated blood pressures, persistent elevated blood pressure,
Yes, sir.
home recordings. So would you then start the patient on antihypertensive or will collaborate with us, try to take off anxiety and then subsequently assess hypertension both together or first blood pressure and then anxiety? What will be your approach?
Sir, see, the answer lies in your question only, sir. If you're saying that the patient has done a home recording, because usually in office settings and hospital settings, the BP will always be high because the patient is anxious. But if the patient is sitting at home and then, as I've told the patient कि आप 5 मिनट बैठिए तब अपना BP लीजिए, क्वाइट रूम होना चाहिए, आपको पीछे चेयर में बैठ के लेना है, मतलब अगर वो ऐसे ले रहा है and still the BP is high, then definitely sir it is not because of anxiety. Then and plus sir, in such patients I'll tell you, sir हम ना इसमें भी experiment करते नहीं, we don't start the antihypertensive. What we do is we ask the patient to take ABPM. We tell them the cost of it. We tell them they have to show to a cardiologist and ABPM, especially sir in young patients, because usually in young patients we see a lot of cases of anxiety. So उनमें तो sir definitely we go for ABPM. And sir that is the most tedious job because we have to counsel them. ABPM is not a very cheap procedure. Now it is quite costly because 24 hours से वो machine जो होते हैं आप पे लगी रहती है. So they equally, and plus a cardiologist can only read ABPM. We can also, but cardiologists भी उनको interpret करके they take out a baseline measurement. So sir these days what we are doing is, especially in young patients, we ask the patient to do ABPM. And plus if the patient says no, then अगर home measurement भी सर उनकी ज़्यादा आ रही हैं, घर पे रहते then definitely sir we have to first we have to start antihypertensives for
So
sure.
you're saying most of the efforts now are being actually to establish the construct, clinical construct, and then move ahead.
Yes. Yes, sir. Yes.
I think the topic is about hypertension. One of the question is like postural drop, postural hypotension.
Yes,
There
sir.
are a lot of psychiatric drugs which can create it, like
Right, sir.
a lot of antipsychotics. So if
Yes,
that
sir.
kind of a thing happens and we are not bound to remove the drug, we have to continue the drug. So what
Yes,
should
sir.
be our approach to counter that, Dr. Manira? In the sense,
Sir,
yeah, like
sir, if
people
the patient is on antihypertensives also, or the
no,
patient is only having
only on antipsychotics. So maybe like increased fluid intake can we give, or any role of any fludrocortisone or the steroids come there, or routinely it is managed.
so we usually don't start fluorocortisone steroids in such patients because orthostatic hypertension मेन चीज क्या होता है सर, वैसी चीजों से काफी मास्क हो जाती है, सिंपैथेटिक एक्टिविटी बढ़ जाती है, बायोरिसेप्टर रिफ्लेक्स जो होता है वो चला जाता है. So the thing in that we do is sir that we refer the patient to psychiatry OPD and we tell the psychiatrist that you have to decrease the dose because
Modulate
we
that.
cannot do anything for that. Yes sir. Yes, and obviously check if there is any antihypertensive which is causing that. Otherwise sir, we with post because sir the patient is going to be very upset. वो उठेगा गिरेगा फिर डिजीनेस होगा तो इट्स नॉट गोइंग टू बी. एंड प्लस सर यस देयर इज वन थेरेपी दैट वी कैन डू, दैट इज जो आजकल बैरोरिसेप्टर रिफ्लेक्स थेरेपी आ रही है जिसमें वी गिव इलेक्ट्रिक स्टिमुलेशन. बट सर देन अगेन इट इज नॉट वेरी कॉमन इन इंडिया, इट इज नॉट डन इन इंडिया.
Is it not? I mean, I keep telling, especially patients who are on my patient on quetiapine or on at TCAs, elderly patients. I tell them to don't get up from the bed suddenly. Sit in the bed.
Yes sir. Yes.
And how they tell you in the airlines, move your legs a bit or then get up.
Yes sir.
Is
Yes
that
sir. Yes.
that's a good advice
Sir,
to counter
sir,
most of
it
the
does help a lot. It does help a lot, but there are a lot of other things also that happens with orthostatic hypotension that I have seen also in my practice. That maybe sir you must have seen that patient when he eats also. After that also patient will feel dizzy. which is actually very opposite. And that is why I'm saying that activation of sympathetic nervous system baroreceptors reflex, it is the most important thing in orthostatic hypotension. So usually the opposite thing is supposed to happen. When you don't eat, then you feel dizzy. But in such patients, what happens is when you eat, postprandial dizziness and vertigo is very common. So there's so many symptoms that the patient will have with this.
I think one more question, Dr. Manira, you're already
Yes, sir.
speaking for last 1 hour and 10 minutes.
Yes, sir.
Like caffeine, I read somewhere caffeine upper limit, safe limit is 200 grams for migraine. For hypertension,
Yes, sir.
something of that sort?
So
Hypertension
usually when a patient, I'm really sorry, sir, I have not read that, but I'll tell you, if a patient comes to me in the OPD, I just say that avoid caffeine. That's it. Because the amount of it, some people say that I just have one black coffee in a day, but in such patients, because it leads to tachycardia also, we always say that it is better that you avoid caffeine.
I think with this, Vishal sir, we are done with the question answer sessions.
Yeah. Dr. Rachit, if
Sir,
आप कुछ पूछना चाहें, if you want to add anything.
And you have to
Dr. Manira, one question which was of my interest in the chat box was,
Yes, sir.
is there any relative or absolute contraindication of telmisartan in ECT? Like we give electroconvulsive therapy.
Yes, sir.
Something of this sort, if you know about it.
No, sir, I'm sorry. No, sir.
Anything of association of lithium, we are giving a patient lithium and some selective serotonin reuptake inhibitors. Now,
Yes,
if
sir.
this patient is given any antihypertensive, what should be the choice? Something on this.
Sir, as I told you, if the best drug that I found has no contraindication is nebivolol, that we give at 5 milligram OD, and thiazide diuretics again is a contraindication. We cannot give thiazide diuretics to the patient with the patients who are on SSRIs and who are on lithium. And plus one drug that I found is because it's a new drug. So nebivolol 5 milligram once daily is a drug which does not have any contraindication with any antidepressant or lithium.
And I think, sir, if I added nebivolol also is pro-sexual, sir, in its properties as an antihypertensive. So that context also it can help us.
Yes, sir.
Sir, we are almost done with our questions. Over to moderators.
Thank you, madam. One question that was there, actually, I wanted to
Yes, sir.
get back again. Any patients where we have stopped antihypertensives, madam? Can we stop antihypertensives at any point of time? If so, for what reasons?
Okay, sir, unfortunately, we cannot, because the only thing that we can do with antihypertensives is we have to taper the dose slowly. So, like we have increased the dose slowly, as I gave you the example of the case also, I started on one drug, then another drug, then third drug. So, the same thing goes for stopping also. If the patient comes to me with hypotensive episodes in the future after visits, then I'll slowly decrease the drug. But we cannot stop them suddenly.
Thank you, madam. It was wonderful. And the amount of questions that are in the chat box clearly shows the enthusiasm that it generated. And
Yes, sir.
thanks to you, and thanks to Vishal Chabra sir and all the others. Sir, over to you, sir.
Dr. Pawan, is there a mercury thermometer behind you? Mercury, sorry, BP apparatus behind you, sorry.
Yes, it is there, sir. Yeah.
Nice, thank you.
Over to Tufan.
Mercury is almost banned now, sir. I think it is now
Yes,
more
sir.
about aneroids and all, if
Yes,
in
sir.
case we are hyping.
And so you can buy that also. It is very good. So because I'm telling all my patients to buy that arterial blood pressure. It is just it's a small device. It just get connected over your arterial pressure, and it gives you a very accurate reading.
What is the
It is
cost
very
of
good. Sir, it is 4,500. Yes, sir. It depends upon company to company, but it's quite
Vishal
on the
sir can
heavy.
afford it easily?
Huh? Yes, I can.
Sir, there are few questions which we have missed out, probably because of the time constraint.
I think, sir, because of most of the questions are also related to core psychiatry aspects.
Yes.
We can, sir, over to Tufan sir, for the Thanksgiving and the final.
Final comments.
Thank you, Dr. Manira, for your enlightening talk.
Thank
And
you,
there is
sir.
a point of importance, considering that many of our patients are above 60 years of age in India. If you take the incidence of obesity, hypertension, diabetes, depression, and allied diseases, the total incidence will cross 200 to 250%. That means there is a lot of comorbidity. And we face that in management. So it's not very easy because the patient is being treated what someone has posted. That when we give, suppose we have advised a patient and necessary, he goes somewhere and gets diagnosed as hypertension. And then it is quite important that all the practitioners should be aware that consultation liaison is extremely important and they should not jump on to give the thyroid. So not that we treat always the patients with comorbidities. Patient is diagnosed, maintaining well, goes somewhere else, and patients windows up very much. So that is, and in that age group, there are a lot of comorbidities. Up to around 60-70% people have more than 2 or 3 illnesses. Not talking of the arthritis, etc. That is quite common incident that we face. Your talk has been excellent. It will be
Thank you,
very
sir.
much helpful. Thank you, Dr. Monera.
Thank
And
you, sir.
thanks, Dr. Sharma, for your kind presence
Thank
and
you.
contribution. And Pavan Kumar, Dr. Pavan, thank you very much. And thanks, Dr. Sobi, Dr. Bisal. And thanks all the participants and thanks to our audience. Good night.
Thank you. Thank you,
Have a
everyone.
nice dinner.
Dr. Manira, sir, we will call her, invite her once more to prime us with other aspects of medical management, sir.
Yeah.
Sure, sir. Yes, sir.
Thank you so much. You're very nice,
Thank
Dr.
you, sir.
Manera. Very nice.
Thank you, sir. Thank you.
Okay, thank you.
Thank you so much.
Good night, I'm
Thank you,
ending.
sir.
Thank you.
Thank you, Vishal sir. Thank you, Shobit sir. Thank you, Panpati sir.
Sir.
So, आप
Good night.
meeting end कर रहे हैं? Dr. Shobit, you'll end the meeting.
Yeah.
Yeah. Thank you. Thank you. Bye-bye.
Thank